First, I would like to thank the Egyptian Society of Gastroenterology and all my partner in management in this very strong session. I will start by my presentation about the upper endoscopy back to the basic. Gastroscopy considered the coronary stones in all endoscopic procedures. So examination start by 6 points. It starts from the oral cavity, larynx, including the vocal cords, esophagus, stomach, duodenal bulb, and the second part of the duodenum. This is the proper posture of the upper endoscopy. The ideal form is left lateral position of the patient, and I have to know to make any posture according to the patient general condition. First, I have to know also the structure of the scope, as controlling start by knowing the structure. This is the structure of the gastroscopy. The distal tips of insertion of the tube, it including imaging guide lens, light guide lens, air water nozzles, opening of the biopsy. This is the whole components of the videoscope system. It includes the LCD monitoring and video system, light source, and I have to know all this manufacture of the scope. See what is the up and down, left and right, pushing forward and backwards, and also to make air inflation outside the patient. The endoscopic grabbing method, the main part of the scope in the left hand, and also it appear in a photo. Then B and C, the grabbing method in this manner, but it's not right to be in the D and E. It's like exploring the road. Pre-intubation preparation and the identification of the lesion, knowing the connection part, main frame, and D and E is the wrong posture of the patient. Intubation of the scope from the oral cavity into the pharynx is very important. I have to make a curve to fit the tongue of the patient. That's the ideal picture. I have to see it, and to avoid the B and C picture, it is mainly in the main trachea and the bronchi of the patient. Always be central to avoid any misleading or to miss any lesion of the patient. Full description of the anatomical site is very important. This is a video about upper endoscopy. I start by examining the scope outside the patient. Then this is the vocal cords, central. Exploring the antrum. Then the second part of the duodenum, and trying to withdraw with full inspection of the duodenum and the bulb. It's very important to inspect the incisura, the common site of ulcer. Then to examine the cardia, making right and left. Backwards. The gastroesophageal junction exploration. As I told you before, always be central. The cardia is incompetent. backward, small sliding hiatus hernia, mainly the diagnosis during withdrawal. And we will back with this picture exploring the two vocal cords, trachea, and the hypopharynx. This is a different lesion, small sliding hiatus hernia, incompetent cardia, and prolapsed gastritis. This is a different gastroesophageal reflux up to Barrett's esophagus. This is a patient of complaining of melena. I make up an endoscopy for her, a gastric antral vascular ectasia, and this is after application with hemospray with proper hemostasis. This is a perforated bulbar ulcer. I make for her here a combined treatment by injection and application by 2 claps. This picture after 48 hours of application, complete closure of it. Always start your journey from sterilization and disinfection room. Tips and tricks, especially for you, well training, lookbook, you have to know when to start and when to stop. You have to check your system by yourself, keep observation of disinfection and sterilization, and also protect the scope. And it is very important to explain the procedure to the patient and also the results. Thank you very much.
Thank you, Dr. Maali.
Dear colleagues,
I would just like to give a comment on what do you think about the reporting, because I think we have a problem here in Egypt in proper reporting in the endoscopies, especially the
yes,
upper.
It is very important reporting and to speak all of us with one language, especially in description. It facilitates the follow-up of the patient.
Any other question from the panelist? Any other question from the panelist for Dr. Maali before we have our next presentation?
Dr. Maali, thank you for the presentation. It was lovely and refreshing. What do you think is the average time we should spend inspecting the stomach?
It depends according to the patient lesion. Myself didn't give to me a special time or actually a proper time for examination. It depends according to explanation of the patient or also explanation of the lesion. But it average from me myself 5 to maximum 7 minutes.
That's excellent. I think we should emphasize the fact that we probably spend less time in the stomach. I think most gastroenterologists spend less time than they should in the stomach. We should inspect the stomach more and more. Your time is excellent, I think.
May I comment, please?
Yes.
Hello, I'm Dr. Sharaiha from Jordan. It's a great pleasure to be here amongst friends. And this Digestive Disease Week has been always in the forefront of gathering international speakers. I remember when we first started, I was introduced to the gastroscopy. I was in England, and they were recommending to use both endoscope, forward-looking scope, and side-looking scope, because at that time the scopes were not malleable, and we could not see the cardia very well, and we could not see the duodenum very well. But nowadays, with these scopes, it's marvelous, and you see everything. But as our commentator has said, that we should really all have the international guidance for writing the reports very well. And I see the differences here amongst is, whether you have hernia, whether you have reflux, and if you, LA reflux, LAB reflux, and you spend you can see almost 60% of the reports that you have a grade A or LA reflux. And really, this is where you see it more in private, unfortunately, in private practice rather than in the other, sources, because they want to tell the patient that he has something. And I think it's really important to unite what we are writing so that everybody understands the rest, what we are doing. Thank you.
Thank you, Professor Zeyad.
Our second presentation, we share Adolfo's presentation. Now with our second presentation, Professor Adolfo.
Dear colleagues, it's an honor to be here with you today. Special thanks to Professor Zakaria and the organizing committee for the very kind invitation. I'm going to show a few videos of non-variceal upper GI bleed. The first case is about the treatment of a post-variceal banding scar bleeding, recently published by our team when I was working in Chile in Catholic University. So in this situation, it's not clearly described in the literature how it should be treated. In this case, there was a bleeding 2 weeks after a previous banding. I tried to band the bleed inside the scar, but the tissue was hard and the band slipped. I did place the bands below, trying to decrease the blood flow to this side, but there was still bleeding. And even if it didn't look very abundant, the narrow esophageal lumen quickly became full with blood. So it was a bit difficult to identify the very specific site of bleeding. Water flush and the cap used for the banding did help in finding the site of bleeding, because with the cap we can push on the mucosa trying to stop the bleeding. And then when we move the endoscope and with the flushes of water, we can see where the bleeding is coming from. However, I did have to put more than one clip until I could find the precise site of bleeding, which was finally clipped with permanent hemostasis. So in fact, this bleeding, as you will see, was arterial. So I think that the bleeding from an ulcer has to be treated the same way, regardless of whether or not the origin primarily was a variceal bleeding that was treated on the first occasion. So that's the scar, and now that's the precise site where the clip has to be deployed, and this resulted in
Can we increase the picture?
As you can see here, this case was quite surprising to me. This 85-year-old lady who was admitted with melena came to the endoscopy room. She was stable. However, I was very surprised to see in retroflexion this spotting bleeding, which was quite torrential. And I thought that she would become unstable soon, so the treatment had to be delivered as soon as possible. My first choice would have been an over-the-scope clip, which unfortunately I didn't have at that moment. Normal clips in a fibrotic ulcer, which has a hard tissue, frequently result in slippage of the clip, so it gets detached. So the next one is a thermal treatment. So I tried with a coag grasper, which is a very reliable method for treating bleeding from vessels. However, it did decrease the volume of the bleeding, but the bleeding persisted. And I'm sorry because the video doesn't show clearly the effect because it's been edited and they made a short version, but it still continued to bleed. So then I used a bipolar probe. This is a gold probe, which did stop the bleeding, but I felt more confident applying additionally a topical method such as a hemo spray. and which resulted in a permanent hemostasis, and the patient was discharged. But I wanted to show you this case so that we can see the different tools that we should have available in such important bleeds. I want to show you this case of a patient who had a bleeding from an ulcer. He was on NSAIDs. I want to discuss the stigma of bleeding seen in this case, which I would call a visible vessel. But in fact, it's a tiny clot attached to the vessel. We injected with adrenaline close to the bleeding site. We could have started further from the vessel as well. This is a frost sign, which is said to happen because there's air in the needle. And then I used the APC argon plasma coagulator, which the experts in bleeding think that for non-varicose bleed doesn't reach as deep as other contact methods. However, it's a very safe method. It's a non-contact. Even if we, in the end, always usually touch the tissue a little bit, we try to avoid doing that. And now we are cauterizing the small clot, but in fact, I thought that the vessel might still be viable. As we can see now, the respiratory movements had an important effect, and it made it a bit more difficult. We could have used a plastic cap to push the tip of the scope against the mucosa. But at that time, this was 2005 in Tenerife, where I was working. I didn't use it frequently. Now we managed to treat the vessel, and now we're much more confident that hemostasis will be achieved and that the risk of rebleeding will decrease. And there were more ulcers, and this resulted in permanent hemostasis. This, we can see this visible vessel, which is pulsating. This patient in hemodialysis and with a lung cancer had endoscopic treatment for an acute bleed, had a cardiac arrest, had embolization, and still rebled. And the surgeons were taking him to theater for surgery, but they asked us to have a look and see if we could apply some sort of definitive treatment. So my first option, of course, there was a over-the-scope clip. In this case, it was a padlock with which we don't need to use any forceps to grab the tissue. But of course, we have the over-the-scope of Vesco, which was the original one and most frequently used. I don't have any conflict of interest, I must say. That clip had been placed by my colleague who did the first endoscopy to show the area to the radiologist for the embolization. We are targeting the origin of bleed, the vessel, in more or less the middle of the image. I don't want to get the whole ulcer, just to bring the vessel more or less to the middle of my view. And by using suction, this could have resulted in bleeding. Fortunately, it didn't. What happened now is that in order to deploy the padlock, the assistant has to press a button and they didn't have enough strength to do it. Another one had to take over and push a bit harder. And now the clip has been deployed, and we will remove the cap and make sure that it has worked. Over-the-scope clips should be in our armamentarium for the treatment of non-varicose bleeding. They can be life-saving tools. We can see that the ulcer is there, but the clip was deployed. This is a case of bleeding from a very large gastric cancer that you will see in a patient with an inoperable gastric cancer with metastasis, with a very severe bleed, where we were asked in the ward to see if we could apply any treatment or see if there was any origin from the bleed. So there was a lot of blood, some food, and there was no active bleeding and no certain precise origin for the bleed. We couldn't identify any vessel, but I decided to hemospray, to use a topical method with this mineral powder. It's said to sorry, so we are applying the hemospray. Yes, so with the hemospray, recommendation is that it should be used on the bleeding lesions. However, as long as the surface of the lesion is not dry, as it was not here, the powder will still form a crust, as happened in this case. So there's no active bleeding, but we completely covered the surface of the ulcer. And we can see it nicely here, how the crust was formed. Of course, there's a liquid in the stomach, and it could make the crust last a short time. There's a subepithelial lesion as well, so we can see, but this resulted in hemostasis. The patient was discharged, and the patient still lived for more weeks, which was something that the family was very happy about. And the hemospray for the treatment of neoplastic lesions was initially described by Professor Parkin's group in Canada in a publication in Endoscopy. So this is the last case. I want to show you how to treat this case, intraprocedural bleeding for an ESD in a neuroendocrine tumor in the stomach, where there's frequently bleeding. In this case, I initially used a coagulation forceps, a coag grasper, which we use by closing the forceps on the bleeding side and then flushing with water. And if we see that there is no further bleeding when the cups of the forceps have been closed, it means that we have grabbed the vessel. And then we apply soft coagulation, and it's very useful. We can also use other type of bipolar forceps. There's further bleeding. The lesion is attached to the muscle layer, and I prefer now to use a Purastat. Is the hemostatic gel, as you know, which can be used to treat intraprocedural bleeding or decrease the rate of delayed bleeding on post-resection ulcers. And it is formed by a synthetic polypeptide, which forms a scaffold on the tissue. And we managed to continue the dissection. So my dear friends, this is all I had to show you today in this 10-minute plus presentation. Enjoy that excellent Congress, and please, all of you and your families, stay safe. Thank you, my friends.
Thank you, Professor Adolfo, for this elegant presentation. I think we are short of time, so we need to pause for the next session. I would like to welcome Professor Dr. Hani Shihab to moderate the second session, third space endoscopies.
Good evening, everyone. Pleasure moderating this session. It's one of the most favorite topics nowadays, and one of the exciting topics, which is the third space endoscopy. Perhaps a few years ago, it was something that we talked about as if it's something futuristic or experimental. But as we will see now from our presenters, that it is something that has now become a daily use or daily technique that we've been using in different problems. So our first presenter will be Professor Ihab Shahada from Jordan. He will be talking to us about EMR and some complex cases that he will be showing us. Professor Shahada, will you proceed, please?
Assalamu alaikum. It's great to be here. I would like to thank Dr. Serag and the organizing committee for inviting me to be here. I've been with you almost all day, and I've learned a lot. Hopefully, I'm going to show you today some of real practice in a general practice, rather than a tertiary center place for EMR. I'm going to show 3 cases, but I'm going to first do an introduction. Colorectal cancer and large polyps account for up to 5% of colonoscopies. and you can have large polyps that need to be removed. Now, large polyps require either EMR or ESD to provide complete resection. And if you can do that in one piece, it'll be great because it will be critical for comprehensive and histological examination and subsequent decision-making. Now, there are different protocols and procedures for EMR. Inject and cut seems to be the easiest and probably the most widely available and requires very little setup in addition to the regular setup of a good endoscopy unit. Now, colorectal cancer remains to be a challenging cancer in the world. In Jordan, it's second most common cancer in men after lung, and sometimes it competes with lung and becomes the first, especially in men. Now, this is the first video, and what I'm going to show is EMR of 3 different grades of difficulty in our patients. This is a lady, she was probably 68, 69 years old, and she was seen by a colleague who does not do EMR. And this patient, although the biopsy came hyperplastic polyp, she was so scared and she was referred for surgery. But after being referred to me, I offered her endoscopic mucosa resection. And as you know, even hyperplastic polyps above 1 centimeter need to be removed because there is 2% chance of having an adenomatous component, which subsequently increases the chance of cancer. Now for EMR, this is the simplest. This is a raised lesion. This is Paris 2A. It's a raised lesion. It's easy to see, and you can inject it to separate it from the underlying muscularis propria, and subsequently you can try to remove it completely with a snare in one piece. And if you do that, you allow complete examination for the deep margin, the side margins, and you could completely remove the whole lesion and the patient is cured with no subsequent need for intervention. So in this case, I injected all the sides, I raised the lesion, it raised very nicely, which tells you it has no actually invasion or adhesions into the muscularis. You can see the snare placed on the lesion easily, and in one piece, I was able to remove it completely. My protocol is to move in and out or to move the snare as you cut, because if the lesion is big, you get more burn than cut. But if you use this, it's easier to move through the cut mucosa. And you can see the lesion is completely removed. There's a tiny nodule that was taken out separately with a biopsy forceps and turned out to be a normal mucosa. So this was a hyperplastic polyp that was totally removed in one piece. Now this is the second one, and this is a cirrhotic lady. She's child A to B and came with FET positive, and she had multiple polyps. This polyp in the rectum was the largest polyp. It took around 35 to 40% of the circumference of the rectum. And it came over a fold, as you can see. It's behind this fold. So it was very difficult to inject the other side. And I can tell you that because I tried to inject the other side to left it towards me, which would be perfect. Because if you can't do that, you might try to remove it in one piece. This was a 2.5 to 3 centimeter lesion. And I injected the whole lesion and I was able to separate it from the muscularis propria. But then trying to remove one lesion that you cannot see the other end, and over a fold is almost a contraindication because the chances of catching mucosa and having perforation is very high. So this is a lesion that needs to be removed in piecemeal. And this is what I intended to do. Now, when you inject, I inject usually adrenaline, one concentration, 1 in 10,000 to 1 in 100,000, preferably 1 in 100,000. And you can either inject at one time before you remove the whole polyp, like we did the first one, especially if you have an intention to remove it in one piece. But if you have an intention to remove it in piecemeal, sometimes it's easier to inject one side and then go to the other side. So you can see, now it's a policy of mine. When you evaluate the polyp, if you by any chance evaluate one part of the polyp to be more dangerous than the other part of the polyp, and that's the polyp you need to make sure that you remove in one piece with all the adjacent tissue so that you can evaluate that pathologically correctly. In this lesion, you can see the whole lesion looked actually okay. There was no more dangerous places. I removed it in piecemeal, but then the edges or whatever, any adenomatous tissue that you think is present needs to be removed, either with a regular forceps or with a hot forceps if you have that. But once you're done with taking all the gross tissue and you make sure that there's nothing remaining, it's very reasonable then to basically, with argon plasma coagulation, I usually burn the base of the polyp if there's any submucosa left, and the edges. And this is for microscopic remnant and not for gross remnant. There should be no gross adenomatous tissue left in the lesion before you do this. And what my policy is, I remove all the big polyp in one piece or in pieces, but I put them in one bottle, and then the biopsy goes into another bottle, because that's the tissue that's remaining around the edges. And that will tell you whether the edge is clear or not. Now the last one, and this is a more difficult lesion, although it's somewhat smaller. This is a secant lesion. And this lesion was biopsied by a colleague of mine and turned out to be a tubulovillous or a villous adenoma with high-grade dysplasia. But instead of removing it in EMR, he took aggressive biopsies, and then he told the patient to go for surgery. So all the irregularity that you see in the polyp is based on biopsy. And the way I can tell that is I did see the colonoscopy of my colleague. So this lesion had no irregularity before this. Otherwise, if I see this and there was no biopsy, this is an indication of malignancy and you cannot remove this. Now, this is in the secant, the thinnest part of the colon. It's overlying a fold, which tells you you should not remove this in one piece. So this is an indication for piecemeal. Now, biopsy, unfortunately, biopsying a lesion that's amenable for EMR makes your life very difficult because it poses the risk of perforation secondary to adhesions that are actually created by the biopsy forceps. So in this lesion, although I was able to left it, you could see that the central part where the biopsies were taking did not left as good as the rest of the polyp. If it did, then removing the whole polyp in probably one piece or two pieces would have been easier. Now, you can see here after I injected the whole polyp away from the fold, it did raise beautifully. I did inject the center because with biopsies in the past, telling you that there's no cancer, it's probably safe to do that. And when you have a poor lifting in the center, that's probably, again, if you're sure it's not cancer, might be acceptable. So in this case, I'm trying to remove, hopefully in two pieces, but that did not work out very well. I could remove the first piece, but the second piece was adherent by adhesions, as you're going to see in a second. So you can see all of this is fibrous tissue. The part here is fibrous tissue, and that did not allow removing of the second part. So I inject more to left the remaining, especially that this is adrenaline, this is not a colloid solution. So with a little bit of time, it gets absorbed. Probably colloid solution in such a case could help because it takes more time to dissipate. And you can see that despite injecting quite a bit of solution, the adherent part did not left very well, and you could not remove it I could not remove it with a snare. So I started taking the biopsies, and again, those go into a different bottle to make sure that the deep part of this lesion has no invasive component or dangerous component. So you biopsy all the adenomatous tissue you can see, you leave none. And then you do the argon plasma coagulation at the end. So you could see here, after removing the adenomatous tissue, I'm trying to remove the fibrous tissue as well, just to make sure that this is a fibrous tissue and not an invasive malignancy. And this is how the lesion looks after removing all the gross anatomical or adenomatous tissue. And you start the argon plasma to the edges and to the center of the lesion to make sure all the left submucosa and the edges for microscopic lesion is completely cleared. Now, all of those patients came back for a follow-up, except the lady with the hyperplastic polyp. And for months, you could only see a scar and nothing else. And the surgery was totally avoided on those patients. So what could go wrong in a patient where you're doing EMR? Bleeding is a major thing that we look for. Now, bleeding depends on the site of the EMR. So for the stomach, immediate bleeding is somewhat rare and it's easily controllable, but delayed bleeding is common, especially if you go to the proximal third to 2/3 of the stomach where the vessels are bigger. So delayed bleeding can happen around 4 to 5%. The esophagus, bleeding is rare. Colonic lesions, the bleeding is in the range of 1 to 1.5%. Now, you control bleeding like many other areas, like our colleague just a second ago showed us an excellent way to control bleeding. The most common way we do this is either by clipping, which especially if you see a vessel, or by actually cautery. Now, if it's an ooze, an argon plasma coagulation is really excellent for that. What about the second most feared complication? Perforation is the second most common. Now, colonic perforation is actually very rare. It's less than 1%. The stomach seems to be more common, and the esophagus is around intermediate in between. And closure of the holes, like you can see here, most of the time is actually achieved very easily with clipping. Now, there are other complications, including strictures, especially if you're doing EMR in the esophagus with multiple lesions like Barrett's. And if you're doing it at the pylorus, of course, reactions to sedation like any other procedure. And again, transmural burn, a burn to the muscularis propria can happen and usually is managed by non-steroidals. Now, how do you prevent? And I think perforation and bleeding, prevention is the key. And if you look at this very nice multivariate analysis, it tells you for bleeding, now the most common is comorbidities. If you have a patient with comorbidities, bleeding, if he needs to be on aspirin or Plavix or whatever, that increases the chance of bleeding. And the worse the tissue. So if you have a cancer that you're removing by EMR or ESD, the chance of bleeding is higher. Now, if you remove the polyp in piecemeal or one piece, it really makes no difference for bleeding, but it makes a major difference for perforation. So if you remove in piecemeal, you significantly increase the chance of perforation, 18 times compared to in-block resection, and it's even more than ESD. And the second thing that increases perforation in addition to piecemeal is the procedure duration. And of course, that reflects the difficulty of the procedure. So the more time you spend doing the procedure, whether it's EMR or ESD, you have a higher chance of bleeding. And thank you very much.
Thank you, Professor, for this lovely demonstration. We will now shift to Professor Sharif Andraus, who's joining us from USA, who will be giving us a few tips and insights into the poem for achalasia.
Right. Good afternoon. It's about 11:50 New York Times, and I wanted to make sure that you're able to hear me and see my slides, so just give me a moment to share my screen. I would like to thank Professor Serag Zakaria, who's always, kind enough to have me participate in a lot of your activities. I'd like to also thank Dr. El-Sawy, Maali El-Sawy. She always, gives me kind reminder to get all my stuff ready on time. I just wanted to confirm that you're able to see my slides and you're able to hear my voice, and then I'm going to go ahead and start. Okay, So today I was given a task to talk to you about perioral endoscopic myotomy and third space endoscopy. And I wanted to make this talk to be a lot more practical in terms of, talking to you about a lot of the things that currently in 2020 is adapted and accepted as the standard of care. I'm not going to focus much on studies. I believe that studies you can always look at and read in a journal or search in a PubMed. I'd like to give you a lot more of our own personal experience, some of the pitfalls, some of the things that we do and we look for. All the cases that I'm showing you, except of some very few slides from gastrointestinal endoscopy, is my own cases and my own techniques and things like that. So basically, achalasia is a Greek word that means a failure of a ring of muscle fiber to relax, and that's meant for the esophagus. And it's an unknown etiology. If you have patients that come to you from South America or lived in South America or any certain tropical areas, you may be dealing with Chagas disease. There is degeneration of the myenteric plexus, and it results in impaired relaxation of the lower esophageal sphincter. Comes with that is, due to the chronicity of that, is a dilated esophagus, esophagus that doesn't move very well. Patients usually present with dysphagia, regurgitation, chest pain, and a lot of them describe what they have as quote unquote reflux. Manometry definitely did help to create a revolution in understanding achalasia. It's not one size fit all, as they say. There's definitely type 1, where you have high lower esophageal sphincter, but complete absent contractility, and those are very challenging. You have type 2 that has more of a esophageal muscle pressurization, and then you have type 3, which has the diffuse esophageal spasm. And we will talk about why POEM will be the go-to and the preferred modality for the treatment of, in particular, type 2 and type 3. Type 1 can be really challenging to talk about. This is just to show over the different types and what's the difference in terms of the IRPs. In type 1, you get a very high IRP. In type 2, you get a normal IRP, but you have some discoordinated peristalsis, where we call that pressurization. And then type 3, definitely you get the spastic type. There is a new entity that a lot of us clinicians struggle with, which called the EGJ outflow obstruction, where you have symptoms of dysphagia, symptoms of regurgitation, chest pain. You do a manometry, and then those patients don't fit any of the achalasia types. They don't fit the criterias. And there is not enough sufficient evidence of peristalsis to make them either a type 1 or 2 or 3. And in the US here, there's a lot of work going on to treat those patients with the EGJ outflow obstruction using perioral endoscopic myotomy. Again, manometry created a revolution for this because we're able to understand diffuse esophageal spasm, jackhammer esophagus. I can remember on the top of my head multiple patients who had admissions to our hospital with chest pain described as severe pressure, elephant sitting on the chest. The pain radiates to the arm, to the jaw. It was always thought of to be a cardiac event, and then they undergo this vigorous cardiac workup that's completely negative. And then long and behold, they get endoscopic workup, they get manometry workup, and then this is a jackhammer esophagus or diffuse esophageal spasm. For jackhammer esophagus, you need a lot of the contractility. You need DCIs for more than 8,000 and multiple swallows of liquids and thick liquids, and also noted in barium studies. Again, I'm just running through this because I would like to focus more on technique and third space, but you all know treatment of achalasia is pneumatic dilation. We're going to talk about it. Surgical myotomy, Hiller's myotomy, followed by fundoplication, injection of Botox, which is, I definitely advise against it at all costs, unless maybe a one session to bridge a patient to more definitive therapy. We only use it here for patients who are in their 90s, who might not be, really a surgical candidate, by advise against Botox injection. Pharmacological therapy with medication never proven to work very well. It's maybe something that the patient would use, intermittently, calcium channel blockers, sublingual nitroglycerin. It's never a long-term therapy. And then we're going to talk about POEMs or perioral endoscopic myotomy. So how about where the POEM came from? So as you all know, there has been a change and progress. I like what someone says, that a lot of time we talked about these things at futuristic procedures, but we do it now. We do it every day. In fact, we do it this week. We did multiple palms this week. But you get what's called endoscopic piecemeal resection, for large colonic lesion or gastric lesion, as the prior lecture and the professor spoke about in detail in a great lecture. And then, endoscopists said, can we do better? Can we resect these in one piece? And that's the ESD, endoscopic submucosal dissection. And while people are performing ESD, especially in the Far East and Japan, it came to realization that there's something that's called this third space, which is basically a space that can be created between the mucosa and either the other side of the mucosa or the mucosa and the muscle. And if I am able to put a tool or an instrument in that third space, expand the third space, use the third space to reach to other organs or other areas, then that's third space endoscopy. So where's the word third space endoscopy come? It comes from that slide that you're looking at, where you expand the submucosal space to create quote unquote third space to put your scope in. And I like to resemble it to either snorkeling, where you not only swim. So mucosal resection is you swim on the surface. Submucosal dissection, you work in the submucosa, that's like snorkeling. Or, when you do a palm, you're more like diving. You're more closer to the muscle or floor of the ocean or the sea. This is a case of an ESD of a gastric lesion by the antrum with high-grade dysplasia intramucosal cancer and creation of a third space, as you can see. And then, it came about from doing a lot of third space cases. This was a colonic ESD that we ran into a perforation situation. You can see the peritoneal fat. You do you look at that, and if in a regular endoscopy you see that, they're in trouble. But when you do third space endoscopy, this is something that you may see and you get comfortable with, as long as you understand your plane, you do it safely, you use CO2, you understand how to address this at the end of the procedure, and you do not compromise the patient safety. This is again third space. This is the space of the submucosa, putting in a knife into the submucosal space to create resection. And then coming to POEM. So POEM is basically, and we're going to talk about the history of it. It's a procedure that was thought of by a cardiothoracic surgeon and endoscopist, Dr. Anawi, who's obviously a world-renowned, who had the interest in performing myotomies for patients with achalasia through natural orifice. So basically accessing the lower esophageal sphincter through the oral cavity. It starts, if you look at the picture all the way to the left, but creating a submucosal blip or an entry point, and then dissecting through the wall of the esophagus. I'm going to show you multiple pictures and video on how we do that. And then performing the work in the lower esophageal sphincter and then closing. So the A is creating the bleb, B is dissecting all the way through down to the lower esophageal sphincter, C is performing the myotomy, D is completing the myotomy, and E closure of the tunnel. And as easy as it looks, it's a very tricky procedure. It requires a lot of training, a lot of what I call, and I tell my fellows, very fine hand motor and eye coordination. You have to really be very good endoscopically. If you're very good with ERCPs, with EMR, ESD, this is something for you to learn. It takes a lot of training. It takes a lot of understanding of where you are, what is your surrounding, where to start, what are the pitfalls, and how to perform this successfully and safely. So the way I like to explain this to my fellows, that if you look at the anatomy, and this is not a diagram to scale, it is just more of an outline. The blue circle is the esophagus. The hexagonal shape in green, that's your spine. The two brown sides are the lungs. The heart is, you can see the heart obviously toward the 11 o'clock position. And then your big beast, which is the aorta, is at 7 o'clock. When you perform palm procedure, you want to do your dissection and work either at 1 to 2 o'clock, which is that yellow semicircle, or in 4 to 5 o'clock, and that's the yellow and semicircle in the bottom. So there are two approaches. The anterior approach, where that, yellow part up top, you tunnel and you go there. I'm going to show you that. Or the posterior approach. And if you remain with within those planes, you are very safe. You will not create any life-threatening complication. The worst that can happen may be some pneumothorax or some pneumomediastinum, which is manageable. But if you are not aware of your planes, if you are not aware of your dissection, tracks and tunnel, and you are blindfolded to what's happening next to you, you can easily injure the aortic artery or injure someone's lung, and then, obviously can hurt someone going after a non-invasive procedure. So these esophaguses are challenging. They're twisted. Some of them can be sigmoid esophagus. Some of them can even as dilated as a stomach, to that picture to the left. They have that characteristic appearance of a very tight sphincter. You see a lot of frothy saliva. Sometimes we see candida esophagitis, where the liquid pools. If the patient is supine and flat, that's where your 6 o'clock position is. That's where your spine are. And you can see that here in the picture to the right, we can see the spine impression, very classic, more towards 7 o'clock. This is what I call the mucosal entry point. You create a submucosal injection to create an entry point, a bleb. You dissect through it, as you can see to the left, and to the right, you create an entry point. I'm going to show you a video for that. Then to the left is your entry point, and then your scope goes into that tunnel. Now you are in that third space. You can see to the right that the knife is sitting on top of the muscle. You are, quote unquote, underwater, as if you're diving or snorkeling, meaning that the mucosa is above you. The floor of the esophagus, which is the muscle, is underneath you. Just like when you dive, you have the surface of the sea above you, and you have the floor of the sea or the ocean underneath you, and you are working into that. You have to be very mindful and careful, seeing vessels through the third space. You have to coagulate those as you go. You cannot afford to have a massive bleed in a tunnel because it's a very tight space. You have to be very aware of very subtle finding. For example, a little tiny bleed to the right, you may be able to see during regular endoscopy. It might not matter much to you, but in third space, you have to be completely aware to control that bleed. I've had situations that I've seen something little like that, and I ignored it and moved on. And within 30 seconds, this filled my tunnel with blood, and it was very challenging to clean and look. Again, you control all the bleeds, you coagulated. To the left, you see a vessel that was partially coagulated. This vessel is not completely controlled. This vessel needs to be addressed again in a complete coagulation. I'm going to show you a video. You see to the right that there is a vessel that's partially coagulated with that white coagulum in the middle, but the rest of the vessel is still there, and this also needs to be addressed. You have to always work close to the muscle, away from the mucosa, which is, again, on top of you, and the muscle is in the bottom. It's the opposite of everything that we do. If you listen to the EMR lecture that was given before me, it tells you stay away from the muscle, stay close to the mucosa. I am telling you in third space, in POEM in particular, not in ESD, in POEM, to stay close to the muscle and away from the mucosa. And that's the difference, that you protect the planes of the mucosa, because that will be your flap that will protect you from having a perforation. This is from a nice paper that was written by Bishara and Anawi about the pitfalls of working in a POEM tunnel or third space. As you can see to the top left, you always want to have that muscle at a 6 o'clock position, nice and straight. You don't want to have the muscle twisted to the right or to the left, but that, again, it can create a mucosal injury. So you like to be at the A view. You don't want to be at the B or at the C view. You always want to stay straight. You always want to check your path. You always want to come out of that tunnel. As you can see in those pictures, I had some muscle injury in my third space endoscopy, which is okay, because I would rather injure my muscle, which is eventually I'm going to cut doing a myotomy, rather than compromising my submucosa and mucosa, which would be the flap that I'm going to be using. Again, Botox gives a lot of fibrosis. That case to the left, and also in a close look up to the right, you see the mucosa and the muscle are very adherent together. And my third space is very tight, very challenging case. This lovely lady was 82-year-old, had multiple Botox injections every 6 months for like 15 years. It was one of the most challenging POEMs that I've done. And again, that's from a repeated Botox injection. So if you have a patient who's coming in and you know that this patient had Botox injection, you have to be, again, very careful and very vigilant in doing your third space. I advise you that if you're learning how to do this, to avoid the cases that were Botoxed for so long, and to start pretty much with naive esophagus that was not instrumented, because that will make your life very easy, especially in the beginning of your learning curve. You always want to have what I called wide narrow. You want to have a wide view where you look at everything, but you always want to have that focus view like a camera. So like when you take pictures at a wedding or an event, you always like to have a view where you see everybody, but you also would like to have another view where you focus on one person or one face. In poems, you have to learn how to have a wide view and a narrow view, a focus view and an overall view. As you can see, as you dissect sometime to the picture to the left, you see that the mucosa up top prolapses down and touches the muscle. So you have to be very careful with these mucosal prolapse, and you have to protect your mucosa. When you go down and you see that there's a lot of mucosa that's prolapsing down on your muscle, you are probably at the GE junction. You have to be very careful. You have to expand the surface. And a lot of time we cut the muscle just to bypass through, and I'll show you that in my video. These are the pictures of the myotomy. Initially, Enoui was doing circular myotomy, leaving the longitudinal muscle of the esophagus alone. Now all the endoscopists, and I'm sure a lot of you do these POEM procedures, know that everyone now evolve to full thickness myotomy, especially in a posterior approach. It's very safe. It also, we don't have a lot of data about recurrence of achalasia or failure of POEMs. POEMs has been around only for about 5 to 7 years in a large, multi-center trials. But people prefer full thickness myotomy. It worked just as good as the circular muscle myotomy. When you do a full thickness myotomy, as you see to the picture to the left, I am seeing pretty much adventitia and mediastinum. And probably next to me is the spine. Again, I'm completely away from the aorta. I stayed in my plane. You don't see muscle anymore. The muscle is split open. And as we work, as you can see to the picture to the right, using that IT knife, you see that when the muscle splits and you have full thickness myotomy, you get to see the picture to the left. After the myotomy is completed, you make sure there's no bleeding within your tunnel. In this picture to the left, you see at 12 o'clock, this is mucosa prolapsing down. It looks intact. The muscle is split open, and then you see adventitia or mediastinal cavity in the bottom. We close the entry to the tunnel, to the esophagus, and then you have completed myotomy. There's a lot of technicality about how long of a myotomy do you do above and below the GE junction. Again, people started by doing 10 centimeter or 12 centimeter myotomy above the GE junction and 2 to 3 centimeter below. I know a lot of my colleagues only do 2 below and 8 above, even 2 below and 6 above. And I know even some centers, they do 2 below and 4 above. They say you really don't need to do an extended myotomy for type 1 and type 2. And pretty much, you can get away by doing a, excuse me one second. By doing an extended myotomy only for type 3. This is now the anterior approach. So this is another esophagus where we approach the perioral endoscopic myotomy from the 1 to 2 o'clock position. You can see now everything, on a circle is upside down because we're working at the anterior approach. So you see the submucosal bleb, you see the entry to the tunnel, you see the muscle up top, you see the mucosa in the bottom. Again, you go in like diving. You are inside a third space. You work close to the muscle. We dissect around the vessels. If we see a network of vessels, we dissect around them. We coagulate them, as you see to the left. We do a myotomy, and now the myotomy is done, obviously, from top down because we are in the anterior approach. And then here is a full thickness myotomy. You see to the left. Some people like to suture the entry point in the mucosa and the esophagus after they're done. Others like to do clips. There was multiple series that showed that the sutures take longer and they're no difference or better than the clips. The clips are just as good. Pitfalls, things to watch for. This is the case to the left, a picture of mine. I was tunneling and I felt that the planes changed as I was getting toward the GE junction in the sigmoid esophagus. So I came out from my tunnel. I'm looking now at the mucosal surface. As you can see, I created another false track to the left. It's a wrong track. If I'm not careful, if I'm not checking my planes, that track can, side me and takes me into another organ and can create complications. You always have to be very careful in doing your, tunneling and understanding your plane. In the picture to the right, from that prolapsed mucosa, you can see that there was a small mucosal perforation that has to be addressed after you're done with your poems. You have to go and find this. Some people would put a wire through to localize it, or go from the outside and close it before they, they complete their myotomy. But you have to be careful with these things. Again, in the NOE paper with Bishara that's published in GIE, the references in the bottom, if you like to review it after the lecture. It's very important as an endoscopist, if you decide to do that, to understand landmarks in the esophagus. They say that the blue arrow shows you the left main bronchi. So this is a plane, which in picture B, that we don't come close to. We always work toward either 1 to 2 o'clock or 5 to 6 o'clock. So we're away from that left main bronchi that's around 11 o'clock. You have to be mindful and away of the aortic arch, because again, when you are in a submucosal space, a lot of the, organs might not look the same. We're endoscopists, we're used to intraluminal endoscopy. We're very familiar with intraluminal landmarks, but we're not so familiar with extraluminal landmarks. That's why we have to be very careful. You stay to the plane, as I showed in my diagram of the layout, either 1 to 2 o'clock for anterior approach or 5 to 6 o'clock in the posterior approach. Good paper. It talks about a lot of the pitfalls and do's and don'ts. I really recommend that you read it if you are interested in endoscopic myotomy. Botox fibrosis, as I said before, reiterate, as you can see in the picture to the left, very challenging. It was very tough to do. Again, a lot of fibrosis. The submucosa is completely adherent to the muscle, adherent to the mucosa, and there's traction. You can see that to the picture to the right, not as expandable of a third space. Again, do not ignore bleeding. Do not ignore, any little vessel that's oozing. Do not ignore any little vessel or that it was not completely cauterized or coagulated. As you can see to the picture to the right of the screen, there's a vessel there that's bruised. You cannot leave that, because dealing with delayed bleeding in third space is not as dealing with delayed bleeding and luminal endoscopy. So if you do an EMR, the patient goes home, there's delayed bleeding, you can go back in and access. But in a tunnel like that, to access that tunnel back in endoscopically can be very challenging. Be careful with sigmoid esophagus. Nagy Reddy from India and some of his colleagues spoke about doing what we call endoscopic landmarks through fluoroscopy in sigmoid esophagus, because again, a lot of time, as you can see in picture B, the scope can make a turn and it can, might not follow the normal anatomical line. These are small case series. A lot of it is good, is good information, good techniques, but not, fluoro is never really adapted as necessary for perioral endoscopic myotomy. I'd like to show you some videos. I did a little bit of a lengthy video because I wanted to show you the techniques, but I'll try to skip a little bit. I don't want to take a lot of time. I only given 15 minutes for this task. So this is just to show you the poem. You can see 6 o'clock is where this, where the fluid is. This is the lower esophageal sphincter. And do not push through it. You have to use water, and you can see the pressure, how tight this is with all the force. And then we pop into the stomach. Very tight and retroflexion. I see my spine, which is 6 o'clock. I'm doing posterior approach, completely far from the aortic artery. I'm doing my submucosal bleb. I have to do a nice and full injection. Here I use 3% hetastarch and saline and methylene blue. Do not use any epinephrine in your solution when you inject into the tunnel. This is my entry point. As you can see, I use a lot of dissection to widen my entry point. As you can see, now I'm using my water pump to slide under the surface. The surface is up top at 12 o'clock. Now this is third space. I'm working into the submucosal space. I'm very careful. I'm working very close to my muscle, away from my mucosa. My mucosa is up top at 12 o'clock. I don't see it. I'm working very close in the muscle. Little vessel that I see, I coagulate. I don't like to work deep and far. I work shallow and close. A lot of time I tell my fellows that when you do endoscopy, you know, you are far, but when you do third space, you're very close. You're looking like this. You have to kind of put the lens of the scope into the space. This is something that takes a lot of time to learn. You are very, very close. In a lot of the endoscopies that you've seen of controlled bleeding and EMR, you're very far. I'm very careful not to break into vessels. I inject away from it to create a space and a cushion. I coagulate very gently. I use coag grasper with these big vessels perforating from the muscle at 6 o'clock all the way to the mucosa at 12 o'clock. I make sure that the vessel is completely coagulated. Again, I'm dissecting. I'm going millimeter at a time. Anything that's bleeding or oozing, I coagulate. I do not ignore. Again, I'm moving forward. I wanted to show you this again. I'm working close and close to the muscle. I'm coagulating vessels with my knife, which is okay if you're experienced to do that, but I'm coagulating the vessels or all the way up to the surface. I'm coagulating the source of the vessel. And then if I'm not satisfied with a coagulation of an artery or a vessel that's in a submucosal space, I still use my coag grasper to do it. Now I'm in a very tight space. My muscle is very close to the mucosa. I cannot expand it anymore. This is my GE junction, very tight. I'm in the submucosal space. I'm at the GE junction. You can see muscle. It's very sticky to the surface of the mucosa. And I'm seeing that from underneath. A lot of, you know, adhesions, a lot of fibrosis from the chronicity. I inject excessively. And then I will pause here for just a second. I am receiving a call from Professor Serag.
Thank you, Sharif.
Yes.
We enjoyed, Sharif.
Yes.
You are very short of time.
Okay, so I'm going to stop right here.
Enjoy very much.
Okay, sorry about that, that I took over from the time. I'm sorry, and I will look forward. It's very hard to talk about third space endoscopy and POEM in 15 minutes. I will look forward maybe for a more dedicated session, and I'm sorry if I went over time. And thank you again for inviting me to your you know, your esteemed and successful conference.
Thank you, Professor Andraus. It was a lovely presentation, and you put it so clearly, and you make it seem so simple. I'm sure it's not that simple, but thank you. I think this is the best way to describe the technique of POEM. So thank you again very much. It gives me really now great pleasure to present my friend, that I miss really a lot, and we all miss him here in Egypt, Mohamed Abdel-Hafiz, who is now a well-known expert in therapeutic endoscopy in general, and today he will give us what I'm sure will be a very interesting presentation on STIR, one of the novel techniques for the removal of submucosal tumors. And I'm sure Dr. Serag is saying we'll give you 2 minutes. I will convince him that he will give you 4 minutes. Okay. Okay, go ahead, Mohamed.
Thank you, Hani. Thank you very much. سامعني كويس, Hani?
Yes, perfect.
Thank you very much for your introduction. Actually, I miss you more. I miss Egypt more. Unfortunately, because of the corona, I can't come, but I hope next time we'll be together. I would love to thank Dr. Serag and the organizing committee for this great organization and this great Congress. I also special thanks to Dr. Maali that contacted me directly for this session. I will not take too much time. I think Dr. Sharif with his great presentation already showed us a lot about this tunneling technique. So I will try to make it short. So I will talk today about this STIR technique, a very novel and elegant technique for removal of submucosal lesions or tumors. So what is STIR? STIR is submucosal tunneling endoscopic resection. As I said, it is a technique to remove submucosal tumors using two techniques combined together. The first one is tunneling, and the second one is resection. How did it start, this technique? First publication from case series came from this Chinese group in 2012, who combined the theory of poem, ESD, and notes together to make this technique. So it's a combination of three techniques actually. So the method, first of all, tunnel opening. We have to open the tunnel. I think Dr. Sharif already demonstrated very well how to make the tunnel, how to open it, and how to close it. What will come in between is that we will reach the tumor through this tunnel and dissect the tumor from the mucosa and from the submucosa, from front and from the behind, and then we will retrieve the tumor, and as in poem, we will close this tumor. I think also that is similar to the poem. As we see, we open the tunnel here in picture number A. Number B, we do this, extend the tunnel till the tumor. C, we do dissection of the tumor, which I can say this is the extra, and instead of myotomy in poem, we will do tumor dissection. We will remove it out from the tunnel, and then we will close the tunnel. This is a 3D video, but at the end I will show a real video, so maybe it is not that important to see it. Here we see the dissection of the tumor from the muscle layer. And actually here, exactly also like the poem, it's not important if you will do perforation or not. Sometimes you have to cut the muscle layer completely, and then you will have a perforation, but it's fine because we are protected with this mucosa. That's why keeping the mucosa of the tunnel intact is your protection and safety to finish until you finish this procedure. The mucosa should intact at the same time, the whole time. Which lesions are suitable for this stir technique? Usually, as I said, it is the epithelial or submucosal lesions. They are mostly in the esophagus and the stomach. Leiomyoma or GIST. Leiomyoma are more common in esophagus. GIST is more common in stomach. So the challenges, like learning any technique, first of all, we have to know the indication, the challenge that we have, how to perform it, how to do the post-operative care, and how to manage the complications. So the challenges that we have with this technique, first of all, is the tumor size. This is a meta-analysis, included 28 studies, including 1,000 patients. They said, they concluded at the end, you shouldn't remove lesions bigger than 3.5 centimeters. And another meta-analysis came later on. They said you can remove lesions bigger than 3.5 centimeters. In this case series, they removed up 14 centimeter tumors, submucosal tumors. But we have to take care here how they describe the size of the tumor. They usually, tumor is a 3D model. Huh? It has a long axis and diameter. Usually when they say 14 centimeter, as you see here in this table, I can see the table, 1 second. They measure it in the length, not in the thickness. Why is that important? Our importance is that we will be able to remove the tumor through the esophageal lumen and through the upper esophagus sphincter and bring it out. If it is bigger than 3 centimeters, it would be a problem. I would say that the lesions should be smaller than 3 centimeters, maximum 2.5 to 3 centimeters in its smallest diameter. As you can see here, it is cylindrical shape sometimes, and the diameter shouldn't be more than 3 centimeters. There is case reports where they perforated the esophagus when they tried to remove 4 centimeters tumor. The location is another challenge. So there are good locations, there is bad locations. Good locations, there are the locations where the endoscope will stay straight. This is our tubular esophagus. Gastric body, lesser curvature, as we can see here in this photo, we will have a straight direction. Gastric body, greater curvature. As we can see, we will make a loop in the stomach and the distal body, and then we will have a very good stable position. Bad or difficult locations will be where we don't have a stable position for the endoscope. There are namely the fundus, the greater curvature of the body or the lesser curvature of the antrum because of instability. And block resection is also another entity. It is in literature between 87 to 95%. And the most important for me, the most important challenge here is to this R0, R1, because surgery has better R0 resection rate. But I will try to define what is R0, what is R1, what is R2. R0, we say R0 resection. If we macroscopically or endoscopically see it is complete resection, and the histologist tell us it is a complete resection. We will have R1 situation or RX situation if we endoscopically believe we removed everything, we don't see any tumor anymore, but the histologist is uncertain or say it is incomplete. Sorry. R2, if endoscopically and the histologist will tell us it is incomplete, then it is R2. The problem with the STIR technique, if we will compare it to surgery, that surgery has 99% of R0, endoscopic has 93%. Maybe because of coagulation that we apply, the histologist can say 100% that it is completely resected. I'm talking now about GIST tumor, not leiomyoma. But the question is it important to have R0 resection with GIST? In this study, retrospective analysis, they compared patient after surgery who removed GIST, R0 versus R1, and they didn't find any difference regarding recurrence tumor-free survival rate, which will conclude also in this, wait a second, something here. In this study also, they didn't find in follow-up that there are difference between R0 and R1 patients, which will conclude for me at least that R1 is not that bad after removal of GIST tumors. So the complications with STIR technique are minor. As we can see here, most of in the literature we will find 18% complications. Most of these complications were related to gas insufflation. At this meta-analysis, at that time they used air insufflation, not CO2. That's why we'll find a lot of emphysema, a lot of pneumothorax, a lot of pneumoperitoneum, pleural effusion, mucosal perforation, bleeding, mortality. All together were less than 1.5%. And all complications were managed endoscopically. I will cut it short now, and I will give you a very small example for this technique. We have here a GIST at the subcardial region. So 60 years old female patient came to us with subepithelial tumor. It was in the cardia and the direction of the lesser curvature. It was 2 centimeters long. Endosonography showed it came from the muscularis propria. Here the endoscopic picture of the lesion. As we can see here in an inversion, this is the fundus is here. This is the lesser curvature here, and this is the tumor. This is from direct visualization without inversion. Actually, it is a little bit difficult position because I will have to go a little bit forward with the scope, which will make some instability at this position. Here's the endosonographic picture. Staging is very important. The first hypoechoic layer, I think, here, the first hypoechoic area is the mucosa. Then we have the submucosa, it is hyperechoic. And then we have the third hypoechoic area, which is the muscularis propria. And the fourth hyperechoic layer is the serosa. As we can see here, the tumor is coming out from the third layer, which is the muscularis propria, which can be leiomyoma or GIST. The patient refused any biopsies, any punctures before the procedure. She wanted to remove the tumor. I also have to say that this lesion should always be discussed in tumor board, interdisciplinary tumor board with surgeons, with pathologists, with radiologists. I will try to play the video now. Here is the endoscopic view and inversion. Here is the direct visualization of the tumor. Now we will start to make a tunnel 5 centimeters above the tumor. Exactly the same like what we do with the poem. We inject in the submucosa, then we'll try to come in the third space. The whole procedure took 45 minutes. As I said, we always have to keep the mucosa intact the whole procedure. Any perforation in the mucosa will be considered as a perforation because we don't have any protection from the perforated area. Now we are trying through the tunnel to reach the tumor, which I consider the most difficult part with during the STIR technique to identify where is the tumor, because everything looks the same. Everything will take the blue dye. Now we see a white bulge here. This is our tumor. Vessels are very big problem in this area in the cardia. This is a minor bleeding, and we can coagulate it. It bled more, and it stops. I use usually this triangular knife, this TTJ knife. I used many knives, but I believe this knife is very, very nice. You can use this spray coagulation very well. And it's very rare that I will need a coag rasper. As we can see here, this is a huge vessel. And I will coagulate it and I will continue. I will not need to coagulate it with coag rasper. Here's the big vessel. So I will dissect around it. And then with spray coagulation, you can cut through it and continue. The idea now, we did complete dissection between the tumor and the mucosa. And now we will try to dissect the tumor from the muscle layer. There are different classifications of the depth of the tumor in the muscularis propria. At this case, it is a little bit superficial. That's why we didn't perforate the muscle layer completely. We didn't reach the adventitia, but sometimes you have to make a complete cut of the muscle layer. And with this, you are making an intentional perforation. But as I said, it shouldn't be a big problem as long as the mucosa is intact. Here, the tumor is much more visible now. We'll continue now from behind, where the tumor is attached to the muscle layer. And we are almost finished. I have to say something here very important, that the capsule of the tumor should be intact also. We shouldn't cut the capsule. Capsule rupture during tumor removal is a very big problem in oncology. Although I believe with the STIR technique, it shouldn't be that problematic like surgery, but still we have to keep the capsule intact. Now we cut the last fiber. Here the tumor, after we removed it, the capsule was intact. It looks nice. And then we close the tunnel with few clips. Usually in esophagus, I need like 5 to 6 clips.
Very, very much. It's a lovely presentation. We'd love to stay more, but
I finished. I already finished. Thank you, Hani. Thank you very much.
It's been a pleasure. And now we will shift to our next session.
Until Dr. Basil is ready, what's your opinion, Jean-Francois, for the sequence until now? The upper GI bleeding, the normal upper GI, the third space management and endoscopy, etc. Being the first man of endoscopy in the world. What's your opinion? No, I'm not laughing.
So we move on.
Yes.
Hashem?
Hello? Hello? Hello?
Go ahead.
Go ahead.
I'm very grateful to be with our esteemed professors and colleagues at this really wonderful event that Professor Serag, the heart and brains of this event, is always making every year. Thank you very much. We're really happy with this session on colonoscopy, which is a really challenging procedure. And I'm really happy to present Professor Ahmed, who is a dear friend and colleague, to give us his beautiful presentation on pitfalls in colonoscopy.
Thank you, Mr. Chairman. Dear professors, dear colleagues, it's my pleasure to be with you. And we are back to Earth. We are flying the third space, but important to have this presentation. It's more toward our young colleagues to have the basics of colonoscopy. The title was suggested by our friends, and it's regarding the pitfalls in colonoscopy. To make the story easy, we have pre-procedure, intra-procedure, and post-procedure. Pre-procedure, we'll talk about the indication, evaluation, preparation during the procedure, how to do a perfect colonoscopy, and post-procedure, we need to be careful about recovery and quality issues. You should have a proper indication for colonoscopy. The list is long, including diagnostic and therapeutic procedure for screening and surveillance of malignancy, for diarrhea. But importantly, endoscopy should not be done for acute diarrhea because it's expected to be infectious in most of the cases, unless you expect pseudomembranous colitis. As well as in cases with IBS, if below the age of screening, if it's hardly diagnosed, it is not justified to go for colonoscopy only for abdominal pain or chronic constipation. However, there are alarming features which mandate colonoscopy, namely age above 50, anemia, short symptom history within the past 6 months, rectal bleeding, unintentional weight loss, recent use of antibiotics, nocturnal symptoms, presence of mass, and family history of ovarian or bowel cancer. This meta-analysis found that anemia and short history of bleeding per rectum in univariant and multivariant analysis will yield a positive screening findings. This is number one. Number two, don't see the patient for the first time on table 4 endoscopy. Patient should meet before the procedure, and the procedure should be described and make the indication and the alternative procedure, and what the patient expect to have during the procedure, and the possible therapeutic options. Importantly, to have the medical history of the patient, if he's using any antiplatelets, anticoagulants, if he's diabetic, hypertensive, and the expected risk and complications which may happen, and patient should be accompanied by someone to drive him back home, and to have the contact numbers of your unit so that he can communicate if any mishap occur post-procedure. This can be done either a soft copy or a hard copy to make the story easy. Then we have some contraindication. We should not go for colonoscopy if you expect perforation, peritonitis, acute heart failure, or there is a recent colonic surgery or aneurysm. Doing colonoscopy without proper preparation, we have the discussion with Professor Ray. It should not be done, as up to 25% of patients undergoing colonoscopy have poor bowel preparation. This will lower the detection of small polyps, increase the risk of complication, decrease the completion rate, and increase the time the endoscopists take to try suctioning and the cleaning of the scope. Preparation is important, and it should be discussed thoroughly for the patient. Patient should be kept on fluid diet the night of the procedure, and it either high volume or low volume. But now it is agreed that split dose preparation is most important. It will increase the adenoma detection rate, improve patient tolerance, and the second dose should be taken 3 to 8 hours before the planned start of the procedure. Position of the patient during the procedure is important. Usually we start in the left lateral position, passing the scope in the transverse column. Better to be on the back, and to deeply intubate the cecum. Sometimes the right position is justified, but this is not for every patient, and no every case like the other. There are some blind spots during colonoscopy, mainly around the flexures. So the direction, you should be a cap which make the scope more easy and more stable. And it was found that the use of carbon dioxide or water insufflation or water irrigation is more better than regular air, and it decreases the post-procedure discomfort as it's found in such cases. So in summary, split dose preparation, especially for afternoon cases, CO2 insufflation is better. Water immersion, give it a try for difficult sigmoid. Change the position of the patient is important. Use different scopes in diverticular disease. Use a smaller scope, and cap-fitted endoscopy may help. If you are having difficulty, try something different. So excessive looping is a problem during a colonoscopy. Why? Because of the presence of mobile part of the colon, mainly the sigmoid and the transverse. So if you lost the one-to-one movement, you are in trouble, and you should think of a loop. We have either alpha loop, usually met in the sigmoid, either anterior or posterior due to the anatomical nature, and that can be overcome by just pull back and straighten your scope. Also, the omega loop is a real problem, or an N-shaped loop, where there is a sharp loop between the sigmoid and descending colon. You should try to go through the shade of the lumen and in the concavity of the fold, so that avoid such looping. As we mentioned, trying water exchange or water irrigation is better, and when you deeply intubate the cecum, you can turn to CO2 and inspect it thoroughly. Pressure by your assistant or your nurse is very important. Sigmoid pressure will lead you into the descending. When you are in the transverse, try to hook in the splenic fracture and withdraw to have deep intubation of the transverse colon in the right lateral position, and support of the right line will help you to deeply intubate the cecum. And by pulling back, it's expected to deeply intubate a cecum while you're at a distance of 60 to 70 centimeter. Importantly, when reporting about the case, don't mention at a distance 1 meter, 2 meter from the anal verge. You should have your landmarks when you are prescribing the lesion. Number 5 pitfall is that we should deeply intubate the cecum in every case, and you should identify the cecum by the anatomical landmarks, namely the appendicular orifice and the ileocecal valve, and inversion of the scope in the ileum is justified. Deep intubation of the terminal ileum is by either a bow and arrow, where you hook your scope into the ileum, or you can do it in a retro version as you see in this video, or by using a biopsy forceps to be as a guide to deeply intubate the terminal ileum. Avoid not performing double inspection of the colon or retroversion in the cecum, as you see in this study, that if you go to and through twice in the right side is equivalent to retroversion of the cecum. However, this should be avoided in elderly because of fear of perforation. So if you are not familiar with retroversion of the cecum, don't do it. Also, retroversion can be or must be done in the rectum for proper visualization of the anal verge. Diagnosing piles is common in cases of bleeding. However, you should not diagnose the hemorrhoids as a cause of bleeding unless you see an active bleeding from the hemorrhoids or evidence of recent bleeding. As you see in such case, we have big piles which can be a cause of bleeding. However, with introduction, we found a circumferential tumor. So don't diagnose piles solely as a cause of bleeding. You may have a proximal lesion, and the colon should be inspected thoroughly. This is regarding diagnostic issues. We have a differential diagnosis between Crohn's disease, which is increasingly diagnosed in our area, should be differentiated from TB. This was mentioned yesterday. The longitudinal ulcerations and the granularity of the mucosa favor Crohn's disease, while in TB, transverse lesions and the nodularity of the terminal of the ileocecal valve and thickening favors TB. Biopsy is not helpful, as there are mixing, and if you find caseating large dense granulomas, it favors TB. It is justified to have a therapeutic trial, as mentioned in this study published 2019, for 2 to 3 months. And if there is a response, you are in favor of TB. If not, you should revise yourself and consider Crohn's disease. Again, in patients with chronic diarrhea, don't forget to take biopsies from the colon. If you did not take routine biopsies, you may lose up to 50% of the causes, which is diagnosed as microscopic colitis. And as I mentioned, taking biopsy reveals either lymphocytic predominance or collagenous colitis as diagnosed by histopathology. Number 10, and this would be mentioned in the next presentation, avoid in unprepared colon. In such case, you may lose such a polyp seen and it was removed. Again, avoid making simple polypectomy for an inverted diverticulum or lipoma. We should go in a third phase as we saw in the previous presentation. Lastly, tattooing polyps or large masses is important if you are going to come back for resection or you send the patient for surgery. Then we go post-procedure. We have post-colonoscopy pain or bleeding. Pain is an important post-procedure and expected. However, it is mild. But if you find your patient is decompensated, patient should have a plain abdomen. If there is no air and still the patient in pain, you should go for CT scan. And if proved there is a free air, it can be managed conservatively, or you send the patient to surgery if you are not able to do it endoscopically. Lastly, post-colonoscopy bleeding is a major issue, and it will be discussed in the next presentation. So quality is very important, and the quality improvement is an integral part in practice. Cecal intubation should be at least in 90% of all procedure and more than 95% of screening colonoscopy. Cecal landmarks should be verified with photo documentation. Trans-elimination or finger indentation is not acceptable. Ileal intubation rate should be more than 40%. Adenoma detection rate should be 10%, at least ideally should be 25%. Polyp retrieval rate should be more than 90%. Quality of bile preparation is important. Withdrawal time more than 6 minutes, and the appropriate use of guidelines for diagnostic and surveillance colonoscopy. So the take-home message is that high quality colonic preparation is essential. Good technique is the key to allow a rapid, complete examination. The scope should be advanced under direct visualization. The scope should be shortened frequently to ensure a short, straight endoscope. Abdominal palpation and patient position changes are useful. Confirmation that the cecum has been reached should be made by identifying the ileocecal valve appendix or entering the ileum and visualizing the small bowel. Withdrawing the scope should be take a minimum of 6 minutes. Retroflex gently in the rectum to avoid missing distal lesion. Lastly, audit of colonoscopy outcome should be performed regularly. And thank you. I hope I didn't take too much time. Hello.
Thank you, Professor Ahmed, for this wonderful lecture that covered nearly everything about colonoscopy that a beginner would like to know. And for our next lecture, I'd like to present Professor Motofiq with the wonderful lecture on the improving performance in colonoscopy, which is an very important issue.
Thank you all. Thank you, Professor Zakaria. I think it's great to be virtually in Egypt, not necessarily there with you guys. It's been fantastic. Thanks for having me. I think Professor Serag wanted me to have exactly 10 minutes talk, so it's all recorded for you. It's like a football match.
Hi, everyone. I'd like to thank Professor Serag Zakaria and the team for the kind invitation. I've been invited to talk about a topic called how to improve your performance in colonoscopy. So before you know how you can improve your performance in colonoscopy, you need to know what are the key performance indicators, so what we call as KPIs. The JAG, the Joint Advisory Group on GI Endoscopy, has brought in several KPIs over the years of its existence to improve the quality in colonoscopy. But we know that the two most commonly used quality indicators for research purpose and also for quality assurance are cecal intubation rates and adenoma detection rates. Nevertheless, all the KPIs are very, very important, and they're all interlinked. As we know that one improves, the other also improves. So why is it important? We know that post-colonoscopy colorectal cancer is an issue. We know that colonoscopy is a great tool in diagnosing and preventing cancers of the bowel. However, we do note that it can actually miss cancers. Then we call them as post-colonoscopy colorectal cancers or interval cancers if it belongs to a surveillance group or a screening group. So which are the endoscopies who are more likely to have picorates or the post-colonoscopy colorectal cancers? These are those that have low adenoma detection rates, low cecal intubation rates, or those who do less number of procedures. So why is it important? It's important because we know that these picorates or the missed cancers may actually be avoided. And most of these missed lesions or the picorates are actually present in the proximal colon, which is the right colon. And most of the picorates actually have poor clinical outcomes. So why is it important to increase your adenoma detection rate? By simply increasing your adenoma detection rate by 1%, you reduce your risk of interval cancers by 3%. So colonoscopy is very simple. One is you take the scope all the way into the cecum and you bring the scope out of the cecum, out of the patient. So it's only two things that you do. So you can also improve it by improve the technique to reach the cecum by using the right scope. You may want to use the right scope in particular cases, particularly if someone is known to have a difficult colon to get around, such as when they have diverticulosis or when they have a difficult bendy colon. You may want to use a pediatric scope or an ultra-thin scope. Water-assisted colonoscopy has been found to be useful, particularly in navigating the left side of the colon, the sigmoid, in helping us to navigate through this, and also minimizes the pain that the patient might have, particularly when the patient is unsedated or light sedation. There is evidence to suggest that image guidance is very helpful. In this case, that we use scope guide, which is an Olympus product that has been found to be quite useful in navigating and reaching the cecum. This helps us to avoid loops and also resolve loops and also to recognize loops much better. We also know that we do find tiny polyps on the way to the cecum, and sometimes on the way out, we don't actually see them. So it is quite important to remove them on the way in. And there is evidence to suggest that by removing them on the way in does not actually lengthen the procedure. If you look at the video on the right, you can clearly see a picture of the ileocecal valve, but we also know that examination of the ileocecal valve is not a complete examination. By examining deep into the cecum, by introducing well into the cecum, by doing a deep cecal intubation, you actually improve the outcomes. As in this case, we found cancer, so it's important to take good quality representative images. You have now reached the cecum and you want to bring the scope out. It's important that you visualize quite qualitatively and quantitatively. So you want to have a good time and technique. Looking behind the folds, we're very much used to in the rectum, particularly in the rectal, using retroflexion. We also know that by using the retroflexion technique in the right colon in certain patients, particularly those who are high risk for polyps, we do find more polyps, particularly serrated lesions, as they can actually hide behind the folds. It's also important to wash and clean the colon quite cleanly, and so that we can see better and pick up adenomas. It's also important that we adequately insufflate. All these four methods are very helpful in having better outcomes, and this was observed in Douglas Rex's paper, where he noted that these endoscopists who do all these four tend to have higher outcomes of adenoma detection. We also know by using a stopwatch and when you're withdrawing, you can actually know how quickly or how slowly and how effectively you're withdrawing. We know that this has improved the adenoma detection. We also know that outcomes are better when we're actually observed. So it might be a good idea to have your colleague or your trainee or your fellow to observe you now and then when you're doing the procedures, so you actually improve your withdrawal time and the technique. Serrated lesions are very important. They may be the lesions which actually lead on to post-colonoscopy colorectal cancers, as they are easily missed because they're very subtle, often flat, and with a mucus capon, they look pretty much unremarkable to the naked eye, and often look to have appear to be red on NBI. We know that they are better identified and delineated when we actually do a submucosal lift. And we also know that the detection of these are dependent on the withdrawal time. It's also helpful to have a second look of the right colon. Sometimes once you've seen the colon once on the right side, you may want to reintroduce the scope and have a second look of the right colon, as we know that this helps us to increase the diagnostic yield and increase the adenoma detection rate overall, and also particularly the right side, you can increase it by 6%. There's a study which was done in the northeast of England where they introduced a bundle and all the patients had more than a 6 minutes withdrawal time as a minimum, and used Buscopan, used retroflexion in the rectum, and used dynamic position change. And this, they found that there was a 2.5% increase in the adenoma detection rate and also 6.6% increase in the adenoma detection rate, particularly of those who had much lower adenoma detection before the introduction of this bundle, suggesting that these are very useful interventions that you may want to use in day-to-day practice. Just feedback about colonoscopy improved performance and outcomes. This is a meta-analysis which showed that certainly by offering feedback on the colonoscopy technique and quality improves outcomes. This study shows that there have been several studies that have been done to see whether there's an improved impact on colonoscopy performance by giving feedback. As you can see, there are several different methodologies that we use to improve the outcomes of colonoscopy. And they found that there was polyp detection rates increased in some of the studies. Some showed evidence of increase in the cecal intubation rate. Some showed evidence of intubation time. Some showed evidence of improvement in the interval cancers, suggesting that feedback can actually improve the outcomes and performance of colonoscopy. What about endoscope attachment? There are several endoscopes attachments that have been available. These, you attach them at the end of the scope, but the principle is they will improve the withdrawal and improving the visualization. The summary from my evidence is that the caps can actually improve the endotherapy and may actually help in intubation, but they do not have much role in increasing adenoma detection rate. The endo rings have limited evidence and they're not universally used. The endocuffs are used more, but they have variable outcomes, and the benefits tend to be more in screening patients. There are several technological advances that have been available, both in terms of the scopes as well as artificial intelligence. Often the question asked is it technology or technique? My take-home message for you is technology does complement, but technique is more important. So the take-home messages from Sheffield to Cairo for you is know your KPIs, know your key performance indicators, consider water-assisted colonoscopy, pay more attention to your withdrawal time and technique, think about serrated lesions each time you scope. Feedback has a role in improving key performance indicators. Technology and gadgets may have a role in improving outcomes. I'd like to thank Professor Serag Zakaria and the team for the kind invitation. Should you have any questions, please feel free to contact me via email. Thank you.
Thank you very much, Professor Mo, for this very nice lecture on how to improve performance. I'm sure it will help a lot of people. I'm very happy to also introduce Professor Ahmed Al-Tombari, who will talk to us about difficult polypectomies from A to Z.
Thanks, dear Chairman. Is the voice clear and the image is clear for the presentation?
It's clear, yes.
At first, I would like to thank Professor Serag Zakaria and Professor Maali Ezzat for their kind invitation. We will talk again about doing polypectomy, which is a little bit tricky. We will follow guidelines. We follow ESEHG guidelines. We can say that superficial colon cancer, you say for sessile or flat lesions, or sorry, for sessile or flat polyps, if the size is less than 9 millimeter, you can go for cold snare polypectomy. If the size is more than 10 millimeters, you go for advanced imaging following like Kudu-PIP pattern or NICE classification, or if you're using MDI, assess invasion. If non-invasive, you can go for hot snare polypectomy if the size is less than 2 centimeter, or piecemeal if the size is more than 2 centimeter. For pedunculated polyp, if the head is less than 20 millimeter and the stalk is less than 10 millimeter, you can go directly also for hot snare polypectomy. If larger, you can inject first, and you can be assisted by mechanical applications like endoloop or using endoclips. And finally, if you suspect submucosal invasion, you can go for ESD, or you can tattoo and refer for surgery. So we will start by the first one according to the guidelines, which are polyp more than 10 millimeter, or pedunculated polyp with head less than 20 millimeter or stalk less than 10 millimeter, which is the classic hot snare polypectomy. For this video, after initial evaluation using chromoendoscopy, and you can assess the type of the polyp. We can see here Kudu-PIP pattern type 4, which is suggested to be adenoma. The size of the polyp is more than 10 millimeters. So we decided to follow the classic way, which is injection at first. You can see this polyp is at an angle, which was a hepatic flexure. After injection, we use the classic hot snare. You should choose the type of the snare according to the size of the head of the polyp, ranging from 10 millimeter snare to larger snare up to 3 centimeter. We use large snare 3 centimeter here to capture the base of the polyp. You use different currents to cut this lesion, either using pure cut current, which is not advised by all doctors, or you can use blended current according to the CERM you use, which is combination between cut and coagulation to avoid bleeding. After resection, you should check the base of the polyp and ensure no perforation or no bleeding at the base of the polyp, as we will see here. We can see here clear base with no signs of suspected perforation or bleeding. Then you should retrieve the polyp. This is another example of larger polyp less than or more than 10 millimeters and less than 2 centimeters, which we use the same technique of classic injection. This one is pedunculated polyp, not sessile. So we check the pedicle of the polyp. The pedicle is less than 10 millimeter, and the head is nearly less than 20 millimeters. So according to guidelines, no need here for mechanical assist by either using endoloop or using clips. So we go directly for injection. You can use adrenaline or not in this mixture. I prefer not use in all cases, except especially if I suspect delayed bleeding for patients or on antiplatelet which are stopped before colonoscopy. Then again, we choose the appropriate size of the snare, and we capture the base of the polyp. And I resect here using a blended current after checking of the appropriate grip. Here the pedicle is small, so no fear of perforation or delayed bleeding, especially in this case. Again, after blended current, we check the base of the polyp, and we retrieve the polyp. Moving to more difficult polyps, we can see here polyps according to the guidelines, which have had more than 20 millimeter, or we have thick pedicle or stalk more than 10 millimeter. So it's better to use combined technique. Following injection, we use either endoloop or clip to prevent bleeding from this polyp. This polyp, after inspection, was suspected to have malignant changes on the top of the polyp, and also the size of the head was more than 20 millimeter, and the stalk was thick one, more than 10 millimeter. So we started first by injection, and this time I used also methylene blue with diluted adrenaline. After that, I used a mechanical method to prevent bleeding, which was the endo loop. Sometimes application of the endo loop is a little bit difficult or tricky to be around the base of the polyp, but you should ensure you adequately grip the polyp without gripping any part of the mucosa or the polyp head around the endo loop. After that, after checking, we started to tighten the endo loop. After tightening, the final step is to release the endo loop and move in with the snare above the endo loop to start cutting. Some experts usually recommend to start after when using snare, you start first by pure coagulation for maybe some seconds. Then after that, you can use autocut or blended current after that. Here, the endo loop is released totally, and we go with a large snare, 3 centimeter snare. We catch the base of the polyp or the stalk above the endo loop, applied little bit coagulation, then starting cutting using blended current. Sometimes shaking the polyp to avoid injury of the other side of the wall from the electrocautery current. And final one is checking the base of the polyp to ensure no bleeding after resection. Moving also to large polyps, which is difficult one, which are flat or sessile polyps more than 20 millimeter. This large one was laterally spreading tumor, which is granular type. The lesion was more than 20 millimeter. So we decided to do, after complete inspection with chromoendoscopy, we decided to do a piecemeal EMR, which may be the best option for this situation. Some experts prefer to do ESD, but this is more for lateral spreading tumor, non-granular type, which have more risk of submucosal invasion. Also, we can use long-standing colloids for more elevation time in this situation, like using Volvin, or recently we can use Orize gel from Boston Scientific. We start using preferably not too large snare. We resect piece by piece and checking no residual between the polyps after each resection. And this is the final, I think the final one for resecting the last one, the last piece of the lateral spreading tumor. After that, you should check no residual tissue in between. The residual tissue can be moved by small snare or by even biopsy. And you should finally also inspect that the base of the polyp after resection, no suspected areas of perforation or muscle injury, which should be closed by hemoclips. Also, you can use spray coagulation or coagulation with the tip of the snare at the edges of the lesion to prevent lesion recurrence. Finally, moving to the easiest part, which are polyps less than 9 millimeter or less than 10 millimeters. Guidelines recommend using cold snare polypectomy for this situation. Cold snare can be done without elevation of the lesion like this one. You just grip the polyp and catch it with the snare and just tighten the snare to cut the polyp. Usually bleeding is not so common, and it's like they told that it's like shaving bleeding, which should be mild and self-limited usually immediately without any assist. Sometimes if larger lesions, you are doing cold polypectomy, because some recommend now doing cold piecemeal EMR, which is little bit bleeding or bleedy procedure. You can assess the coagulation with the tip of the snare. This is another example of a small flat lesion. Cold polypectomy can be done again without elevation. Just you can grip the lesion with the snare and just tighten the snare till cutting of the polyp itself. You can also do the same technique after injection of submucosal saline mixed with methylene blue, like this lesion. Methylene blue have no much advantage in this situation, but you can show the border of the polyp after injection, especially if the lesion or the polyp is little bit flat. You can inject, you can see more clearly the lesion, but avoid too much injection, because too much injection will sometimes make it difficult to grip the polyp itself. A little bit we injected too much in this polyp, but finally the polyp was catched totally with the snare. We can see here also again after injection, a little bit suction with pushing down, you can grip all the polyp. And after resection, it's much easier to check no residual polyp by injection of methylene blue. Again, we will use here a water pump to check no residue or bleeding. This is minor bleeding, which is usually self-limited. We told it like shaving, and we check no residual at the base of the polyp. Here we reach the end of the presentation for most types or techniques for polypectomy according to ESG guidelines, and thank you for your attention.
Thank you very much, Professor Ahmed, for this very nice presentation. I just wanted to ask you, how do you estimate the size of the polyp and the pedicles?
You can estimate the size of the polyp by different techniques. The first one is using the open biopsy forceps. Usually the blade of the open biopsy is about 7 to 8 millimeter. You can use it in comparison to the polyp to assess the size of the polyp. The other technique is using the handle of the snare. You can close and measure the handle of the snare, the base of the polyp or the stalk, how many millimeters from the handle of the snare itself.
Thank you.
Thank you.
Anyone else in the audience would like to have any questions?
Professor Dr. Ahmed, may I ask a question?
Please go ahead.
Okay. If you have a non-lifting sign, how you can differentiate between malignancy from scar?
Okay, inspection of the polyp, especially for lateral spreading tumor, is very important before deciding the resection. We have different methods. First, we are using the morphological appearance of the polyp by Pallies classification. For Pallies type 2A or type 2C or type 3, which are little bit depressed or extracavated lesions, they are suggestive of submucosal invasion. The second part is morphological assessment of the surface pattern and vasculature, which is using Kudu-Pit pattern or NICE classification or even GNet if you have magnifying endoscopy. If you have signs of lost pit pattern, which is type 5, either absent or irregular pattern, or if you have neovascularization, this is suggestive of malignant transformation or submucosal invasion. Final step is incomplete elevation. When you have incomplete elevation, this is suspected either submucosal fibrosis if biopsies are taken previously from this lesion, or suspecting submucosal invasion of malignancy, which is assessed usually by surface pattern evaluation.
Thank you.
Thank you very much. Now we move to ERCP and EUS. Professor Zamzami, Ahmed Zamzami available?
Thank you.
Yes,
Ahmed.
sir. Yes, sir, with you.
Huh?
Good evening.
يلا يا احمد. وخش على طول بقى مش عايزين شكر وكده.
Okay. At first, I would like to present my sincere thanks and deep appreciation to my professor, Professor Dr. Serag Zakaria, for this annual interesting Congress and giving me the opportunity to share this great scientific gathering. Now it's my pleasure to introduce Professor Lars Abakken from Norway and his interesting lecture about tips and tricks for successful cannulation.
Lars. Unmute Lars, we don't hear. Lars, we don't hear you. You have problem in your mic.
Can you hear me now?
Yes, sir, we can hear you.
Okay.
You can. Yes, go ahead.
So you can hear me now?
Yes, your voice is very clear. Please.
Fantastic. Okay, so I was charged to talk a little bit about the ERCP and the aspects of cannulation. And as you know, when you do ERCP, this is what you want to do. You want to find the cannula and you want to find your papilla in a nice position. You want to pass your guide wire and you want to insert your catheter and fluoroscopically confirm that you're in the right duct. So this is your ideal situation. Unfortunately, that's not always the case, and I will like to go through some of the elements to improve the likelihood of succeeding. So before you can even get to the papilla, you have to get to it. These are some general ideas of how to succeed with that. And I think for novices in ERCP, you may struggle navigating the stomach in a side viewing endoscopy situation. So I think your number one trick will be to, if you get lost, because typically you will flip back and you will inverse in your fundus and look back into your scope. So then pull back into the cardia and then look to the right, because that's always where your orifice is, and particularly if the stomach has a cascade anatomy, this is when you get in trouble. Sometimes also if you have a large hiatal hernia, that also may cause problems, of course. If you usually have your fluoroscopy running already, so sometimes that can guide you as well, particularly if you're unable to get towards the antrum of the stomach. If you are still unable to get through the stomach into the duodenum, moving from your oblique supine into the left-sided position will usually help you. If you can see the orifice of the pylorus, but you're not able to get to it, then passing your catheter, which you will use anyway, into that orifice and into the duodenum will help guide your scope as well. And finally, if even that fails, or if there is some kind of stricture or some other mechanical trouble of getting into the duodenum, that may be the case, for example, if the patient has a left-sided liver resection, then the mobility of the stomach may cause trouble. Then passing a large caliber balloon, like a 20 millimeter dilation balloon into the duodenum, and then follow that with your scope will help you. And then eventually, if you push a lot of scope, then get to the duodenum, but think that something is not right there, then chances are you have an alpha loop in the stomach. So looping around the fundus into the pylorus. And in that case, you need to push on until you get towards ligament detritus, and then carefully straightening with fluoroscopic guidance, and usually rotation then will be counterclockwise, which is obviously opposite of what you usually do to get into your short scope position. When you get to the papilla, you have to realize that they're not all created equal, of course. And it's a good advice to study it long and carefully before negotiating it, because once you start pedaling around with your catheter, you can cause mechanical trauma and even bleeding. And so observing it before touching it is usually a good way to understand exactly where you want your target of approach to be. And then to successfully cannulate, I think you need dexterity, you need experience, but you also need to think ahead that if what your primary plan doesn't work, then you should already in your mind have a plan B and C and D to know what to do if your initial idea doesn't work. Because if you have those plans in your head, then changing your plan will happen sooner. If you have only one plan, chances are you will persevere trying to make that work even though it doesn't. And so these are some of the elements in that plan B and C thinking that I would like to go through briefly. And one is retaining deep access. So if you have a stent inside, which is sometimes the case, you want to just replace a stent or do something else with a papilla where the stent is already inside, then I think trying to cannulate alongside a stent and place a wire there before removing your stent is always a good idea, because most of the time it's easier to cannulate a already stented papilla, but sometimes it's not. And so in that case, try to get a wire inside before removing your stent. It may save you time and effort. And sometimes retrieving the existing stent with a surrender retriever or a snare may be of value, particularly if that stent is going through a very difficult intrahepatic stricture. Position is important, because the better your position towards the papilla, the more navigational accuracy you have, and the more likely you are to succeed in your cannulation. So if you're really close, that's usually where you have the most accuracy, but that also gives you less angulation in terms of getting into the plane of the bile duct. If you increase your distance, your accuracy goes down, but it does allow utilization of the curvature of your catheter. And if you have a sphincterotome, then that added angulation utility can help you. And and sometimes you can hook your tip of your catheter into the papilla and then push your scope at the same time as you push your catheter to facilitate the right direction of your catheter. And sometimes if you struggle getting in, even though you think it looks okay, then pushing your scope to get into a semi-long or even super long position is sometimes helpful, but navigating in this position is cumbersome for the patient, it's cumbersome for you, so you have to factor that in. But sometimes that change in the angle as well as in the sort of general anatomy of the duodenum may sometimes help you. If you get pancreatic access, because that happens not infrequently, although most of the time you want to get to the bile duct, then you should consider keeping it and utilize it with one of these techniques, double wire techniques or a long wire pre-cut. I think those are the two most important techniques which are valuable in this situation. So the idea of the double wire technique is if you get a wire into the pancreatic duct, then that wire will somehow stabilize the anatomy of the papilla, and it may help you go alongside with your catheter to access the bile duct. So this is an example of that. So this wire goes into the pancreatic duct, and then you go alongside it with another wire and try to angulate yourself upwards. And at least in my experience, surprisingly often, this works. So I think the most important effect of this number 1 wire is to stabilize the papilla and and maybe also to occlude the pancreatic duct. It doesn't always work, and sometimes you just go alongside that wire going into the pancreas again, then you might want to take it out. But I think if you get into the pancreas, this is well worth trying. The other option, if you have a pancreatic access, is what I show you here. So the wire is in the pancreas, you try the double wire technique, and like I said, sometimes it works, sometimes it doesn't. And if it doesn't, then pass your sphincterotome over that pancreatic wire and do a sphincterotomy over that. Because for me, this is way safer than a freehand pre-cut. It's safer, and also it allows you to understand more accurately where you should look for your biliary orifice, because this is a groove of the pancreas, and at least 90% of the time the orifice of your bile duct will be to the left of that. And so when you get a little bit used to understanding the anatomy of this pre-cut visualization, you can realize that this is the place where the orifice of the bile duct is, and getting your guide wire out and in the right direction, you can slip inside. So for me, a sphincterotomy over a pancreatic wire is by far superior to a freehand pre-cut. But sometimes you don't get into the pancreas, you don't get anywhere, and then this is your only option, obviously. So with a needle knife or with a pre-cut 0.20 papillotome, you cut the papillary orifice trying to get into the bile duct. And the ideal situation, obviously, this layer-wise unroofing of the papilla to give your visual clues and to ideally see a spurt of bile to understand that you're in the right level. But obviously, stakes are high here because there is a range of possible complications. And I think the most troublesome issue is that you need really to hit the center of the bulge perfectly and to hit the bile duct, because if you don't, then you will pass alongside it, and then you will continue cutting down deep and potentially perforate the duodenal wall. These are some of the studies published indicating how pre-cut sphincterotomy works. And I think the most important point is that the range of complications is quite wide, indicating that some experts do very well, but some non-experts do very poorly. And I'm trained with the School of Pitticotten from Charleston, who is extremely reticent to do this pre-cut. So I think the most important message is don't do this if you're just replacing poor cannulation technique. So before even considering doing a pre-cut, you should have thought about these things. When to switch, how long should you try before changing? The anatomy of the papilla matters, because if it's a very small, very flat papilla, then the risk of a pre-cut is higher. The experience of the operator obviously matters. The reasons for failure matters as well, because if it's because of an uneasy patient, of a poor positioning of the scope, lack of time, these reasons may not be good reasons to do a pre-cut. And then finally, the indication and the urgency may matter as well, because maybe it's better to stop and call for a friend and do the procedure some other day. But if you do it, this would be the idea. You pre-test the angle of the cut. You insert the needle into the orifice. At least that's what we do. and then pass upwards, ideally along the plane of the bile duct, and then layer by layer try to approach the level of the bile duct. And you really need to cut far enough for the tissue to open up, because otherwise you have no visual idea where to direct your subsequent cannulation attempts. So you do this layer by layer, you try to open it up, and then you change your needle for your catheter, and then try to target ideally some visual bile duct orifice. I'd like to mention also the idea of fistulotomy, partially because this was my first ever international publication back in 1986. This was a study done by my mentor, and it was about papillary carcinomas, where if you have a dilated upstream duct, then you can puncture that dilation by the visual bulge and avoid the papilla altogether. But I would just finally mention a few special situations like intradiverticular papilla, because that's not all that rare, particularly in elderly patients. And if you have this situation, then you should first look for the papilla elsewhere, because sometimes they're not in the diverticulum, you just think it is, but sometimes it is, and then it's usually at 4 o'clock, at 7 o'clock, or on some intradiverticular ridge. And in this case, we had a look inside and didn't find it anywhere, and we had some idea, because this ridge was so obvious, that maybe the bile duct was there as well. And so you can maybe have the idea that it's somewhere here, and using the sphincterotom, I was able to invert the orifice of the papilla into a direction where I was able to cannulate. And I think with some experience, although it's an extra hassle, most of these situations succeed, although you have to spend some extra effort. If the papilla is on this edge or on this edge, you may need to do some other tricks, like placing a clip or a miniature biopsy forceps to invert the orifice. But otherwise, you just have to try to work to find the best access route to your papilla. And also, I think usually, unless it's like this when it's on the ridge, you should probably be a little bit more careful with your cut and rather expand your opening by balloon dilation, because the wall here obviously is thinner. Just to mention as well other situations. So if you have a Billroth 2 situation, then everything is upside down. So your normal sphincterotomy direction doesn't really work, because you have to cut here, not here. So either you have to rotate your sphincterotome, or as we usually do, place a stent and then use a needle knife onto that stent to do the cut, and then remove the stent and do the sphincterotomy onto that. And finally, there are some other situations of, for example, surgically altered anatomy, particularly gastric bypass, where part of this challenge is to get to the papilla in the first place. But even when you get there, which usually is through some quite loopy scoping, you find the papilla here. And although you can see it, it's not that easy to get to. And what you usually then do is to try to slide over it with your catheter and try to find this the orifice. And I think these days we usually use a cap on the scope, because that flips down the ampulla. And then when you get to the cannulation, doing the sphincterotomy is also always usually a little bit cumbersome because the normal sphincterotomes don't work. So what we usually do then is to pass a guide wire and then use a needle knife like you can see here, and then cut outwards as much as we can, and then again expand the orifice with a balloon dilator. So when all fails, I think you should at least consider this list of solution options. Call a friend. Try another day when the swelling or the bleeding has stopped. PTC is an option. EUS is increasingly an option, and surgery finally is an option as well. So to conclude, most cannulations are straightforward, but if they fail, you should have your lined up plan of what to do if your initial idea doesn't really work. Think sequentially and have your options lined up before you, and avoid trying the same failing technique for 50 times because it's likely not to work. And weigh your risks because, as you know, ERCP is a risky procedure, and sometimes stopping and considering the alternatives is a better option. Thank you.
Thank you, Professor Abaken, for this elegant presentation. Now it's my pleasure to introduce Professor Vibroy Rasod from India and his interesting lecture about ERCP and EUS video cases.
Thank you very much, ladies and gentlemen, Professor Serag and his entire team. Lars, I enjoyed your talk. You are from Peter Cotton's unit. I am from Sohendra's unit. So I differ in some areas of pre-cut, but I do it very, very frequently pre-cut in my work. Anyway, so going from Professor Serag said that we are short of time, so I'm cutting my talk into half. I'm skipping the entire biliary part. I'm focusing on pancreatic endotherapy and endosonography confluence. So we all know the advances in endoscopy over the last 100 years. I'll just give you a little brief history and then we move on. Traditionally, when we approach any pancreatobiliary problem or suspect any problems, we have a lot of investigations. And then very rarely we think about EUS as a top-line diagnostic modality before we try to treat the patient. So today, what is our objective? What is the role of EUS in managing complex pancreatic interventions? And I'm not going to touch the other parts. This is for some other time when I'm back with Professor Serag. So in 1969, they all started initially an attempt to opacify the ducts. And in 79, the first PTC was done. And then a lot of efforts subsequently. So almost 100 years is a history. As you can see, 1920, and we are in 2020. It's almost 100 years humanity has struggled to conquer the pancreatobiliary system. The major breakthroughs came by Professor Kawai and Klassen with ERCP sphincterotomy in 74, 75. And then, of course, 78, Professor Nipsohendra, the first man to put a stent in the bile duct that changed the way to manage biliary obstruction. So I cannot move ahead without thanking my mentors, Professor Nipsohendra and Ken Binmola, where I was in Germany in '96 for fellowship. And these are the two gentlemen who influenced me immensely, Ken for EUS and ERCP by Nipsohendra. So I was very lucky to have very good mentors. Coming to why EUS is important for ERCP decision and outcomes. And a lot of times you can possibly avoid an intervention based on an EUS findings. And I'm going to touch upon some of those as I will show some interesting video case capsules which are diagnosed or they were tried to diagnose on various imaging. And when they failed, and that finally we had to do EUS. So coming to pancreatobiliary diseases, we can diagnose stones, tumors, helminths, You can have recurrent acute pancreatitis, staging of pancreatobiliary cancers, tissue acquisition, EUS-guided drainage of pancreatic fluid collections, and including pancreatobiliary ductal drainage. Coming to the complex anatomy, as we all know, and some wise people did mention that it was first described, this organ, in 1788, and since then it has been an enigmatic organ for all of us across the planet to get control over its proper diagnosis and very, very effective management. So if you ask me what is the role of EUS in diagnosis of various problems of pancreas, acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, pancreatic fluid collection, warm and cystic tumors, solid tumors, and other interventions. I'm going to just quickly summarize what is the role of EUS and pancreatic endotherapy interface, how it can change our approach. So this is classically the image I would love to have in color on endosonography, and perhaps in future we will have that kind of endosonography. So just to give you a little whenever we suspect a pancreatic tumor with obstructive jaundice, at least for me, for last 22 years, it has been a standard protocol: EUS, mapping of the pancreatic tumor, staging, locoregional nodal staging, liver mets rule out, mediastinal node rule out, and then you do a biopsy of mass and the node if required, evaluate the portal vein, the supramesenteric artery, and the supramesenteric vein, and then take a biopsy. Now we do only pure core biopsy for pancreatic tumors. Coming from pure tumors, I also do a lot of chronic pancreatitis endotherapy, and this was 28-year-old young man. You can see here that there's a dilated bile duct with stones here. That's the portal vein, and this is chronic pancreatitis, but something was not adding up because there was some irregular hypoechoic area which I could see in a setting of chronic pancreatitis. And believe me, in this 28-year-old young man, there was a hidden adenocarcinoma in a setting of chronic pancreatitis. So ladies and gentlemen, this is the adenocarcinoma we are looking at here, irregular tumor in the head of the pancreas. Now we have contrast enhanced EUS, and also we have elastography, which can assist you to differentiate inflammation from neoplasm. Coming to a similar case of a pseudotumor, an 18-year-old gentleman, a young boy with a mass in the head of the pancreas, dilated bile duct, distended gallbladder. So why I'm talking about pseudotumors? It will alter your management strategies as far as your therapeutic outcome or goals are concerned. So what we did, this boy was advised Whipple operation in several centers in Mumbai. This is a dilated CBD here. We did EUS guided final aspiration biopsy, and it turned out to be primary tuberculosis of pancreas. And all we needed was a plastic stent and antitubercular drugs for this young boy, and that was end of the story. So whenever you see a young patient with a tumor, I just saw a young 13-year-old girl this today with the papillary neoplasm of pancreas. So young people, you have to have a very good EUS mapping before you intervene. So we did biliary sphincterotomy, placed the stent. The brushing was negative, as I can show you here. We did brushing. So what clinched the diagnosis was EUS FNA-B, and then I placed a stent, and then patient was brought in after 3-4 months, and you'll see that the stricture is completely resolved. And this is the beauty of endosonography when you integrate with pancreatobiliary interventions. So when you talk of recurrent acute pancreatitis, we have certain etiological factors, but we do not really take care of pancreas the way we should by early evaluation with EUS. Now, I'm sure all of you here in the audience and the students know acute gallstone pancreatitis. I will tell you what is the pathophysiology of gallstone pancreatitis. Now, this was a solitaire gallstone solitaire. This stone has gone into the ampulla and has refluxed back in the pancreatic duct. You can see the beautiful bile duct, beautiful CVD. And you can see the pancreatic duct stone here. Now, anybody would say this is a chronic pancreatitis. No, this was a stone in the gallbladder, went into the ampulla, and refluxed back into pancreatic duct, leading to severe acute pancreatitis. So endosonography is extremely important because this patient was diagnosed of gallstone 6 months back, one solitary stone. So EUS gives us absolutely fantastic image in terms of mapping of the pancreatic gland, and immediately we intervene. So now we know we don't want to go to the bile duct. Bile duct is clean, gallbladder is clear of stones. So we go straight in the pancreatic duct, no contrast injection because I already know what is there in the pancreatic duct. No contrast injection in the pancreas. EUS mapping allows you to do all these things. So ladies and gentlemen, if you do a very high quality EUS, you can even avoid a pancreatogram or even a cholangiogram. And that's what I do for my obstructive jaundice, malignant biliary obstructions. We do not inject contrast anymore. We do EUS mapping. You see the stone, classical cholesterol solitaire. Okay. Coming from there, a 20-year-old young girl came to me with recurrent pancreatitis. I want all of you to pay attention. If Lars is around, I'm sure Lars, you'll be excited to see this case. There's a CBD, that's a gallbladder. And you see here, something in the pancreatic duct. There was a live ascaria reflux completely in the pancreatic duct here. You can see the gut of the ascaria. You can see that like a stent. It's like a stent-like structure in the pancreatic duct. So this is the power of endosonography mapping of pancreas and the pancreatic duct. I can see the round room here in the pancreatic duct in the body with dilated, mildly dilated pancreatic duct in a 20-year-old female. This is not chronic pancreatitis, mind you. This is just beginning of probably early chronic pancreatitis. Here I'm injecting contrast to highlight the ascaria, and then we managed to drag this damn thing out. You can see this damn thing was sitting in the pancreatic duct. Crazy, isn't it? So we always thought that pancreatic juice will kill ascaria. It does not happen that way. It does not get digested in the pancreas. So this is a myth which we have to overcome. And we, with a lot of tug of war, we finally managed to drag this damn thing out and then place a small stent, and this girl recovered beautifully thereafter. Coming to patient with anemia and CT angiogram, and even a percutaneous interventional radiology could not pick up where was the bleeding from. And when we mapped the pancreas on EUS, we could not see pseudoaneurysm classic, but we saw some abnormal vessels in the ductal wall. And this is the CBD here. This entire pancreatic duct is full of soft stones. Now, those who are not very well trained eyes in endosonography, you may not appreciate it very clearly, but this is what was happening. Hemosuccus pancreaticus. So this young boy, 28-year-old man, was spewing blood from the ampulla. Interventional radiologist could not pick up. CT angio missed it. So I said, we are going to intervene and deal. So compared to the Western counterpart of chronic pancreatitis, we in India deal with a lot different kind of chronic pancreatitis. This is probably genetic mutation related chronic pancreatitis we are dealing with. And therefore, we deal with soft stones, which does not require. So in my practice, 75% of my patients do not require ESWL. They will be managed with endotherapy, maybe in one shot like this. Put stents if there are strictures, and then can bring them over after some time. And this bleeding stopped immediately. If the bleeding would have continued, I would have placed a bumpy stent, a covered metal stent in the pancreatic duct to stop the bleeding. So we just placed the stent and the bleeding stopped thereafter. I'm going to skip this slide. I'm going to skip this slide also, but this is the classic protocol in my unit where we do EUS mapping, pancreatic duct, stone here, bile duct, gallbladder, the same sedation, patient goes for endotherapy, ductal clearance, and end of the story. I'm going to skip this, but we can have something like this patient who has multiple stones, radio-opaque stones, and this is where we need very aggressive pancreatic endotherapy protocol, where we do ESWL, and then we clear the duct, and we do always EUS mapping to rule out any malignant process in the setting of chronic pancreatitis if there is obstructive jaundice as well. So here we placed a pancreatic catheter, and then we managed to do ESWL. I placed a nasopancreatic catheter, and then patient was sent for ESWL in the same hospitalization, and then we cleared the duct after 5 days completely. So in one sedation, you can clear all this thing with very aggressive pancreatic endotherapy protocol. And I'm very proud to say that we have probably hundreds and hundreds of such patients where we have dealt with only endotherapy purely on EUS mapping. Now, if you see a duct like this, recurrent acute pancreatitis, undilated duct, what would you do? I will tell you what we'll do. I want all the experts, ERCP experts on board to keep an attention here on this case, please, because this is going to be a game changer, because we do endotherapy in undilated ducts. I'll tell you why. So when you do a proper EUS mapping, look at the attention here. This is edematous pancreatitis, acute pancreatitis. This boy had pancreatitis, and I'm intervening in pancreatitis. And see what we find. A small soft stone trapped in the minor papilla here. This is the minor papilla. It's a 3 millimeter stone. I don't think any imaging on the planet can pick this stone for me. No best CT scan, no best ERCP. Without EUS, you will be completely lost. So ladies and gentlemen, what's the next logical step? You have to do ERP and in acute pancreatitis setting. So since this patient had incomplete divisum, we did a major papilla sphincterotomy. I do major minor in almost all the cases of recurrent acute pancreatitis. And the reason, see, now I'm doing a freehand pre-cut of minor papilla, freehand pre-cut of minor papilla, and see what we find. Yeah, that's the small stone. So if you do not pick this damn small stone, this boy would have gone for a full-blown chronic pancreatitis after some time. Coming to young babies, now the youngest child I've done endosonography with a radial EUS scope for an adult is a 7-month-old baby. So this was one child who was sent to me with recurrent pain, recurrent acute pancreatitis. The child had again some ductal anomaly, and there was a fluid collection in the head and neck area. So what we did mapping of the pancreas and the duct, and we then intervened for this young baby of 20 months. There was a fluid collection. This is a normal size. Now I'm using a pediatric ERCP scope here because we do a lot of children endotherapy routinely in our unit. You can see the wire here. And when I inject contrast very gently, just to demonstrate that this was a fluid collection which was impinging on the duct and the child was not thriving. So EUS pancreatic endotherapy interface is a brilliant way to handle. Again, for those who are ERCP experts on board here, I want them to see this very interesting case. This patient, young man of 26, I'm mapping the pancreas, that's the bile duct, and there is a large soft stone. Here's a large soft stone at the genu of the bifurcation of the incomplete divisum. And this was in 2 dimensions, of course. So what we did major papilla sphincterotomy, and we went inside. I'll show you how we did it. And I went to the minor papilla first. I have cannulated the minor papilla. You can see the minor papilla coming in. And then this is a major papilla, and there is a stone sitting there. So what I did was I placed a stent. You can see the beautiful mapping of the pancreas here. So I placed a 5 French single pectoral stent from the minor papilla, then entered the major papilla, and see what I'm doing now. I'm trying to go in, but I'm not able to go. There is a stone here, sitting here at the junction. There's a stone sitting here. So none of the baskets none of the things will go ahead. And what we did was, I'll show you quickly. We went inside. This is very important for you to see. And then we did put the basket also, but it did not work out. And therefore we placed multiple stents in the pancreatic duct. As you can see here in this particular video is the same video. And then we placed one more stent, and we brought down a guide wire from the minor papilla into the major papilla rendezvous. You can see that I'm pushing the cannula from the minor papilla outside the major papilla. And then we put one more stent, and this girl had a fantastic recovery out of the soft stones without any major intervention for surgery. So what I'm trying to highlight to all of you is, if you are really serious about pancreatic endotherapy, if you do not do proper EUS mapping of pancreas, your desired outcomes will be far-fetched. Yes, you can always treat patients with ampullary tumors like this. This is a large ampullary adenoma in an 86-year-old patient. We endoscopically resected, and of course, then we stented the duct. This was almost 4 or 5 centimeter lesion, and then we stented both the ducts. I'm going to skip this I'm going to skip pancreatic fluid collection, but I'm sure Lars is around. So probably this was one of the first few EUS guided drainage pancreatic fluid collection way back in 2005. I'm talking of 15 years back. And why I'm showing you this particular video is that the combination of EUS and ERP will prevent recurrence of fluid collections. We have changed over that. Necrosectomies can be done. And of course, EUS guided celiac plexus neurolysis as well. So what is the last on the horizon? EUS guided pancreatic ductal drainage when you have impossible duct to access. But believe me, with the experience we have, it's very, very rare unless you have a disconnected duct syndrome where you need to do this technique. Otherwise, you can do a transpapillary approach, or there is an anatomy which has been altered because of surgery and you need to deal with it. Otherwise, I think a standard ERP is very good for pancreatic endotherapy. So ladies and gentlemen, I'm just going to conclude. Role of EUS in assessment of acute pancreatitis is very important. Role of EUS in recurrent acute pancreatitis, etiology and mapping, extremely important. I think EUS gives you a fantastic experience in terms of pancreatic duct, parenchyma, side branches, atrophy, neoplastic changes, fluid collections. And my personal feeling that you can combine both this modality. Pancreatic endotherapy, I would say, is a subspecialty. This is not ERCP, guys. I'm telling you, this is a subspecialty, and we need to understand the pathophysiology better. Should EUS become an integral part of pancreatic mapping followed by endotherapy? I think this question can only be answered with a multicentric randomized control trials, which I feel is, at least in my setting, is very difficult because I'm in private practice. And this has given me brilliant results over a period of last almost 2 decades or more. So guys, can EUS ERCP interface be a one-stop shop for vast majority of pancreatobiliary problems? I feel for you to decide. Thank you very much. Once again, Professor Serag.